welcome to our educational video series, the 3-minute anesthesia critical care medicine. Today we're going to talk about OB anesthesia, and we're going to discuss something that's not related to epidural or C-section. Today we're going to talk about cerclage. Cerclage is a procedure that's done for cervical incompetence that happens in 1% of a pregnancy. Usually cerclage is done early in pregnancy between the 12-week and 18 weeks. And there are 3 approaches for cerclage, 2 transvaginal and 1 transabdominal. The transvaginal approaches are more common to be done in the OR than the transabdominal approaches. So when you have such cases scheduled, what are the anesthesia options for these cases? So option number 1, if it is an emergent case, like a patient has bulged fetal membranes or there is dilated uterus. In these cases, there is no way to do any kind of neuroaxial anesthesia, no spinal, no epidural, and the only way is to do general anesthesia. In these cases, when you do general anesthesia, you have to be very careful that it has to be rapid sequence induction and there's no cuffing on intubation, because all your aim is to prevent the cuffing and the bulging. And in these cases, usually because it is early in pregnancy, the uterus is small, so the side effects of hypotension or the supine hypotension or the gastric reflux are much less compared to the C-section general anesthesia. If it is an elective case, then your options are open. But remember, it is a short case and usually done as an outpatient. So the best option sometimes is the spinal anesthesia, 1 shot. And remember, it is a short case and outpatient, so you have to give lesser doses. And not only because it's a short case, but also all what you need in these cases is to achieve T10 level. We know in C-section we have to reach T4 level, but in these cases you only need is T10. You can add opioid, or you may not use opioid, because in these cases the visceral stimulation is much less compared to C-section. So smaller doses and T10 level are appropriate for these cases. What about the removal of the cerclage? Because after the 36 week, between 37 and 38 weeks, the cerclage has to come out. So what are the anesthesia options? Usually it's done in the clinic without any anesthesia. But some patients, they develop granulation tissues around the knots, and this will cause a lot of pain. So in these cases, you have to do another spinal shot and provide good anesthesia for each cases. If the patient is in labor or there is a rupture of membrane and they need to remove the cerclage, in these cases, it's very logical to do epidural or combined spinal epidural. That's the references that we used for our lecture. And thank you for listening, and don't forget to subscribe to our channel. Thank you so much.